Hello and welcome everyone to the ESRD National Coordinating Center's Learning and Action Network event for today, January 18th. We are focused on the objective and key result number 3 of Transplant. I am Sarah Eve Schaefer. I'm going to facilitate this call with our guest presenter today. We typically have the ESRD networks, but today we have a speaker from the ETCLC, Tina Dinkel. So very excited for that, and we're going to get started. So just a few logistics. Sometimes these calls can be rather large, so everybody is muted upon entry. I did already begin recording this call. The presentation is available for viewing on the ESRD NCC's YouTube channel, which we will share with the ESRD networks to share within their network service area following the call. That will also include the slides and any significant chat or resources that are shared today. So everyone is muted. We are going to use the chat feature for these calls, and we'll test that out in just a moment. So we just like to level set for the Learning and Action networks. And so we try to share approaches, experiences, questions. We do that via chat. We encourage you to think about how you could use today's information at your facility or in your network. Specifically, if you can apply at least one idea from today's presentation at your facility or in your network, and then commit to just talking to your colleagues about what you've heard today, sharing your learnings and your ideas. For these Learning and Action networks, we like to bring people together, but we also like to leave in action and implement something from the call. So we'd like to test out chat. So we're going to just start with the basic question, which is, have you used the ESRD NCC's change packages across a host of topics, one of them being transplantation? Have you used those in the past at your facility and your network? Thank you, Verna. That was our first one in. And if you haven't used them or you are not familiar with them, the QR code that is there, if you put your phone's camera over that, it will take you directly to the page. So I'm seeing a bunch of no's there. So I will share the QR code again, but it might be a nice idea to go to the QR code and at least look at the change packages there. We do update these every year with tips that we get from interviews from top performing facilities. So these are updated every year and a great resource. The Transplant one has been around for about 4 or 5 years and really a big resource. Okay, so with that, I'm going to pass it over to our special guest presentation. Again, typically we have the ESRD networks and or facilities presenting, but we're really excited today to have the ESRD Treatment Choices Learning Collaborative, or the ETCLC, their Executive Director, Tina Dinkel, with us today to go through. So Tina, it's all you.
Hey, thank you, Sarah Eve. It's a pleasure to be here. Thanks for joining, everyone. And as Sarah Eve said, I'm the project director for the ETCLC Learning Collaborative, or the collaborative that's focusing strictly on transplant. What I'm going to do today is just set you up with some background information, and then make sure that at the end of mine, I've already asked Sarah Eve if I can ask you a couple of questions as well. So hang with me a little bit as I go through. I will leave you with some resources. I'm also going to drop in a link to our change package, since Sarah Eve teed that up so nicely. I'm going to go ahead and drop that in here for you all now. And this is for kidney donation and kidney transplant or utilization. And so that's been in existence since, I believe it was released 2020. And then part of our work includes updating that annually. So you are welcome to take a look at that at some point, and you have the resource available. So with that said, Sarah Eve, thank you so much for getting us started. I will go ahead and change up here. So again, just starting off today with providing you with some background. I'm going to let you know about our numbers, just so you can see the scope of it, talk a little bit about our aims, and then start talking about the successes that we've seen so far, share some key strategies, specifically with the quality improvement teams that we work with, as well as our donor and family and patients teams as well, which I know each of the networks have, and most of the dialysis facilities most likely have a patient group as well. Then we'll have a few minutes for discussion at the end. All right, next slide. Our questions to run on today, which you're used to seeing as well, is how might we improve the communication between the transplant programs and the dialysis facilities? How may we or might we improve the education towards towards transplant? How can we improve the readiness of those patients so that they are ready for transplant? And then one of the primary aims in the work for ETCLC has been reducing the national non-use or discard rate. And next slide. Thank you. So again, just giving some perspective on where we are today as part of the overarching ESRD network program and this collaborative that is supported by CMS, HRSA, as well as CMMI. So the image that you're seeing here is called our program intercepts. I'm not sure if you may have seen it under different conditions or circumstances, but I think it's a great way to put into context all of the work that's taking place, not only into the ESRD program, but some of the incentive and payment models. You'll see the work of the ESRD networks in here and some of the coalitions that they're working on, and then also the NCC that you interact with regularly as well. So just quickly scanning through this, and I'll focus on the large yellow space in the bottom right for the ETCLC collaborative. But currently we have about 80% of the transplant community overall working in the collaborative, all but 2 organ procurement organizations or OPOs. About 80% of all of the transplant centers in the US, as well as 2 donor hospitals from each of those OPO regions, as they were previously known. And then on the next slide, we have more information about how the collaborative itself is working. So I've given you a little teaser on some of the teams and so forth, but let's move into that next. So again, nice visuals around the individuals or the organizations involved. You'll see our aims here on the left, focusing on increasing the number of deceased donor kidneys transplanted, the reduction or decrease of non-use or discards less than 60 kDPI, and those that are greater than or equal to 60 kDPI. And then our third aim revolves around increasing the number of kDPI kidneys greater than or equal to recoveries. The individuals working in this space with us as part of the collaborative focus on our national faculty, where we currently have about 15 representatives, including 3 recipients, transplant recipients. We also have our Leadership Coordinating Council, which consists of associations, membership organizations, and so forth from the transplant community. So our friends at AAKP or ASN, ASTS, the Organ and Donation Transplant Alliance, and so many others that are helping us spread our message. They do convene once a quarter, so our next meeting is in just about a month. And then our patient and donor family group, or PFRs, are subject matter experts. And this is a unique group because it does involve current ESRD patients or folks that are on dialysis, folks that are currently transplanted or may have lost a transplant and are back on the wait list, and our donor families as well. So a very unique mix, giving different perspectives back to the ETCLC organization through different contacts and calls. Again, they meet every other month, and I'll show some of the resources that they've created too. One of the most dynamic areas, and we'll talk a little bit more about this as we move forward, is how we have our quality improvement teams set up. Those consist of 13 adult transplant teams, 1 pediatric team that represents about 23 of those children's hospitals throughout the US, and then 11 donation teams. So for the first 2 years of the collaborative, those organizations met on 25 separate calls each month. What we did last spring is start bringing them together. So the majority of our work revolves around identifying best practices, what works, how to do the work, and then sharing some detail around maybe process and doing some walkthrough. So after doing that with smaller groups, we brought those groups together in the spring of 23. So in total, that represents about 400 organizations working in the transplant space in the US. And again, as I said earlier, all but 2 of the OPOs, 2 donor hospitals per region, and then about 80% of the transplant centers. And next slide. So going a little deeper dive into the quality improvement teams themselves and the work that's taking place. Again, we have them divided in what we consider 3 estates. And so each donor team also has an OPO representative, and each transplant center has OPO representation as well. And while we do try to keep them in the same time zone, they are typically from different regions. That way they can learn across the country what is taking place, different ideas and recommendations. And then also there's the geographic challenges around availability to fly organs from one region to another. Frequency and access to the transplant wait list, and then of course knowing West Coast versus Midwest, the wait times on those wait lists for patients. A few of the ways that we interact are through the pacing events that we host. Those have gone from upwards of 3 to 4 each month, and that includes our pacing events, case studies, and other learning opportunities, to now narrowing down this year to 1 pacing event a month, and then their quality improvement team meeting a month. So everything that we've done so far is 100% web-based or virtual. But the purpose of not only those teams, but the pacing events, is to share real-time information, allow for conversation, Q&A, again, so it creates that learning environment that we all enjoy and benefit from, hearing from colleagues without having to travel. The other areas that we're working in, again, drop that into the chat for folks to reference, but there is a change package, or actually 2 change packages combined, for donation and utilization or transplant. Something I want to point out here on the left is the little teal kidney. That's part of our logo and branding. So I just added those as some things that would be helpful to consider as you move forward. So again, one of the QI team activities includes tracking not only the work that's taking place as far as best practices and promising practices, or things that are up and coming, but having them go through what their PDSA is. And interesting enough, although they're not necessarily called PDSAs at a lot of these organizations anymore, they are still doing the work in a similar fashion. So a lot of times we're finding ourselves drawing out or asking prompting questions in order to get back the information that we need to help spread the full understanding of those practices. So thanks, Sarah Eve. Next. And moving into our patient and donor family representatives, or our PFRs, some of the work that they've been doing and how they contribute to the ETCLC. Again, 25 of those individuals at any given time, but they do have a role on each of those QI teams. So we currently have 2 to 3 assigned to each team, so that they meet on a monthly basis with those professionals, so that they can weigh in on different aspects, provide their experience, having gone through the transplant process, or being a part or a formally making that decision to donate their loved one's organs. Again, providing that perspective to always keep the patient voice and their experience top of mind. They, again, currently meet every other month, and we talk through some of the things that they've heard on their QI team calls, get their suggestions and recommendations on ways to not only bring together the community, but work with each other and different resources that they might be interested in producing based on some gaps that they've identified. They also coordinate or work collaboratively with the NCC directly each quarter. And one of the current projects right now is keeping patients active on the wait list. Then they also work together with the National Patient and Family Engagement LAN on a quarterly basis as well. Then for the ETCLC work itself, they meet bi-monthly. Again, this includes folks that have been transplanted, those folks that may have had a failure and are currently back on the wait list, or maybe they have been transplanted multiple times. And again, having that donor family perspective. It's been nice to see the connection from a recipient that's always been grateful and perhaps never met their donor or donor's family. But now they're seeing what that experience is like from the donor's perspective, and then vice versa too, the recipients being able to interact with those donor families that made the choice. A lot of the work right now is focusing on the expanded criteria or high KDPI kidneys greater than 60. And our next, just giving you some quick background. I won't spend a lot of time here, but just giving some numbers to the work that's been done around recruitment in the fall of 21, which Sarah Eve was very involved in at that time, and where we are as of the end of this past year. So about 2.5 years into the work. The retention has still been high, just as many of you have experienced availability. So while they are actively engaged or a part of the collaborative, it doesn't mean that they're showing or available to participate in every one of the activities and efforts that we're doing, but the numbers have stayed stable, and we're grateful for that level of participation. And in our next, just giving you some information on our current status, if you will. So this is a monthly dashboard that we provide through CMS as well as out to the community. So our contract, interestingly enough, runs from August to August. So it's mid-August to mid-August. So we typically do the data from September 1 through August 31. So as of August 31 for the second year of the collaborative. My little teal kidney down here tells you that we've met 2 out of the 3 aims, specifically the number of DCD kidneys transplanted during that time period was exceeded the target by 3.8% to 22,033 kidneys. And then also for aim 3, KDPI kidneys greater than or equal to 60 recovered for transplant. It ended the option year 1 at 14,116, which exceeded the target by almost 17%. So a lot of great efforts by the OPOs, the transplant centers, and the donor hospitals working together and improving those relationships as well. But most of our work, as you'll see here, for aim 2 or reducing and decreasing the non-use rate for less than 60 or greater than and equal to 60. That's where the majority of our efforts are spent right now. And whether that's through education, whether that's through turn downs and so forth, depending on which organizations we're working with, again, whether it's the transplant centers, the OPO, or the donor hospitals, then their conversations change based on what they're looking at or what they have been doing in the space to decrease their non-use. So thanks for that. Sarah Eve, next slide. And just to give some perspective about the work that's being done, I mentioned earlier the PDSAs, the best practice sharing, and so forth. But one of our activities includes some self-reporting on some of the initiatives or projects that each of the organizations are committed to and working on. Some of them can be 3 months, some of them are upwards of 3 years. So they all vary among those 400 organizations that are represented. So when they provide that information to us, they are asked to qualify it or separate them out if it's an aim 1, aim 2, or aim 3 focus. You'll see here that teal kidney again telling us that that's where we're spending most of our time, or that's where we as a collaborative are spending time. But what you're seeing is the incredible effort that went into the number of kidneys or DCD kidneys over the first 2 years of this work. And then also, while there aren't currently by the numbers, a high number of organizations working in the space to increase the number of KDPI kidneys greater than or equal to 60. We have seen a lot of change just in the last 6 months. So we do expect that to increase as well. And you can see from the results, AIM-3 exceeding the initial CMS target by almost 17%. So again, just giving you a feel here on the work that's taking place within the collaborative. And next slide.
Tina, we had one question in chat, and before we go too
of course.
far down, it was based on numbers. So I'm going to go back a slide.
Sure.
And Christy asked us, does the 49.3% mean the percent of kidneys not used in transplant? So
that is,
yeah,
that is accurate, Christy. Thank you for stopping us and drawing everyone's attention to that. That is the reality that we are living in this country. But we have separated it out specifically to differentiate less than 60 or greater than 60.
Great, thank you for that.
Thank you. And thanks, Gayla. So as we talked about some of those projects and what we have identified through the work of the collaborative, we did a assessment back in the spring of April of 22, just to get a feel for where folks were in the work itself. So as far as that change package was concerned, what were they currently working on? What did they plan to work on? And what wasn't even on the radar? So between that and what they shared during their QI team calls, what they gave us feedback on, different surveys, post pacing events and case studies where their priorities were, this is what has come forward out of year 2 of the work. So in year 1, it was a little larger. Year 2, narrowing a little bit. But again, many of the things that the networks are working on, I'm sure in their coalitions, many of the things that affect the dialysis centers as well are also priorities for not only this collaborative, but the transplant centers you work with, the OPOs that work with them to coordinate the donations, and then the donor hospitals, which originates that work. So the waitlist management for transplants, patient education once they're in center, and then the work that you're doing obviously at the dialysis centers or through the networks. After action reviews or the near real-time reviews. When they decline a kidney, what would they do differently? Why wasn't it accepted? So on and so forth. Utilizing biopsies. There's still some, I don't know that it's necessarily controversy, but different ways that are looked at it. So trying to encourage organizations to utilize that biopsy to help rule in instead of ruling out. So a lot of work going on in that space. And you'll see on both of these lists, the relationships are significant. And that's going to be one of my questions here as we get a little closer to half an hour through the conversation, is the relationships between the OPOs and the transplant centers and those OPOs and the donor hospitals. So for the folks on this call, the relationships between the transplant centers and the dialysis facilities are significant as well. You'll see on the donation side, the utilization of those IDCs or their interdisciplinary councils. So similar to what many of the networks have or you have at your dialysis facility. Very similar work. And then the use of electronic medical records. We're seeing more and more of that, especially with the LDOs, being able to communicate directly with those transplant centers to update records, labs, any changes in medical history, which is wonderful to see. And we know we'll see more of that as the technology continues to evolve. And with that, Sarah, you next.
Sure, Tina. I would also just tee up then perhaps at the end, maybe you could talk a little bit about that KDPI greater than 60 discard rate. I think that number is shocking for a lot of people. And so maybe just a little discussion around that. And then also, although you defined first person authorization, maybe too, why perhaps even though, you know, someone might have a first person authorization in place, there still might be challenges to donation. So maybe just a little background as you wrap up then. Thank you, Tina.
Absolutely. You know what, let's do FPA since we're on this, and then definitely want to talk more about that higher percentage as a group as well. And I know I have some colleagues on, not only from our tackle team, but the networks, and Sarah, you've been in this work as well. So would love some conversation as a group around that. But I appreciate the call out right? It is a significant challenge in this country and within the transplant industry as a whole. And it's not solely on one entity that works through the process. So let's talk more about that. For now, the first person authorization and making sure you have the right approach. The first person authorization is that the donor has declared they might have their heart on their driver's license like we do in Kansas, or depending on your state, they're on the registry. However, the family's choice is different. And so there are some complexities, some legal challenges, and some hesitancy or potential risk by some of the hospitals. And so there's been a lot of education put into the efforts around understanding it, and making the right approach, saying the right thing, understanding where that family is, because every family grieves differently. And one of the key points around organ donation itself, or making that choice to donate your loved one's organs, really comes down to what has been identified as trauma. You are asking a family to make a choice when they haven't even been able to adjust to the fact that they're losing their loved one. So some families come to that faster. Some families have had that conversation with their family, and it's a much easier ask, as well as a much easier answer for those families. But being in that moment when folks are traumatized, going through the process of understanding, being angry, being in denial, so on and so forth, sometimes that approach is going to come off as, I've heard the term twice this week, and Sarah Eve, I don't know if you heard it when you were in the work with us, but that vulture mentality. But that you just want my loved one, or you're trying to take my loved one because you want their organs. And that obviously and absolutely is never the case with an OPO, and I've had that personal experience myself. So all of this is about right timing, or for some of these longer cases where someone may be under observation for 3, 5, 10 days in the hospital, and the OPO does not present until the family is ready to make the decision, or has made the decision to end life-saving measures. The question becomes, why didn't you ask us sooner? Why are you just now waiting after we've been here for so long, and that we would have considered? So a little more about FPA. We can come back and revisit, Sarah Eve, if there's other questions. I do see some stuff popping up. So happy to speak more to that. We're down to our last couple of slides, and we can get into some great discussions. The OPO, thank you, is the Organ Procurement Organization. There's 56 in the US, and those are the organizations that help coordinate between the donor hospital and the transplant center. They are the ones that go in and meet with a family about and making the request for a donation. Going back to our patient and donor family representatives. These are two of the resources that were created last year based on the requests and some potential gaps or some potential opportunities. These were sent to dialysis facilities back in August, but they are publicly available as well on our site. So one of them was around those conversations regarding donation. So what do I need to know about donating my loved one's organs, dispelling some of those myths or misunderstandings around donation and what that is like. Asking people not only to put it on their driver's license, but actually to go into the National Registry, registerme.org, and put your wishes in there. If you want to do only bone and tissue, but not organ, you only want to do lung and kidney, but not heart, you can specify in some of that as well. And then also the second resource is what has been coined as a term of better than dialysis kidneys. That's still a little bit, some folks like it, some don't, but it's you may have heard them called higher risk or marginal, or my favorite just to learn in the last 2 weeks, which we're going to start using, are the missed opportunities. So where are there opportunities? Maybe it is a higher KDPI, but it's incredibly healthy. It's just a little bit older. What else do I need to know about those types of kidneys? Because they do have, each patient has the right to opt in for a high KDPI kidney. And I believe someone would have more current stats than me, but there's something like 80% of patients on the wait list have checked the box or told their transplant center that they would opt in or they would like to be considered for a high KDPI kidney. All right, Sarah Eve, our next. All right, we are at the end here. So let me take a breath, grab some water. Sarah Eve, I know you've seen a lot of questions in the chat.
Sure.
Great group today. Thank you all.
Yeah, and I'll clarify too, right? So these learning and action networks are originally scheduled for 1 hour. In September of last year, we tried cutting them down to 30 minutes. A lot of times we do end up landing right around 40, 45. You know, we don't want to stifle a great conversation at the same time. We realized we could make these a little bit more succinct. So we will be landing somewhere probably the next 10, 15 minutes. Again, great group, lots of folks here, lots of great questions. So yes, I think that, let me go back through, we've talked through some of these things. You defined an organ procurement organization, right? And that's important then from the standpoint that it divides the team who is providing that care in the hospital and then a separate team organization who is working through donation. And it's intentionally set up in that way to Tina's point, right? To be able to, these are two separate organizations, again, with the same mission though, you know, based on donation and life-saving efforts. So we do have a couple questions here. Maybe Tina, you know, was talking about, there's a few questions in there about, you know, what about transplant centers, right? From the dialysis facility perspective, you know, we've perhaps referred patients who are great patients, but hey, maybe they use marijuana, maybe they've refused a vaccination, you know, just maybe some light conversation around, you know, what might be done with the transplant centers, you know, from the dialysis facility perspective where folks might not be listed, even though they might be otherwise great candidates.
I think it's a very valid point. And as we're all aware, there's 223, 226, correct me. I know there's a couple that closed last year, transplant centers, and there's probably 226 different expectations or criteria around those. So in the sense of, you know, being fully transparent, knowing what those limitations are, in the case that was mentioned here about marijuana or vaccination, I am not aware of, you know, a center that might accept it. But I think as marijuana use becomes legal throughout the country in different states, I think there's another conversation that will happen regarding that. Some of the requirements around smoking or other things as well. That's one of the many factors that goes into deciding who can be waitlisted. Anything else to add, Gayla or Sarah Eve? And again, anyone else that's on from the tackle team, please feel free to weigh in.
Great, sure. We did see a couple folks, you know, sent in, you know, that they know in their states that they allow, you know, marijuana use, you know, casual. And so, right, there's, just, as Tina said, right, a high variability between transplant centers. And, you know, right, one thing that the dialysis facilities are doing then is getting to know your local transplant centers, what the referral criteria is. I know iPro has an excellent tool for the states that they are working in. And, you know, I'm going to promote, Tina, I'm going to promote Gayla also to panelist so that if she wants to speak, she can, because right now she's stuck in chat.
Appreciate that.
If you'd like to, I think we're ready then to tee up some of your questions.
Okay, great. And we will, as I read through some of these, I will bring some of them up as well. But I really want to hear from the group. There's a lot going on, as we saw that initial graphic around all the other work. So I know many of the dialysis facilities are obviously working with their transplant centers consistently, and then our ESRD network partners on the phone in their coalition. So I want to hear what works. A lot of the things that you've heard me talk about are around best practice, what moves to transplant, and you saw some of the things that our organizations are working on, but what works for you? I'd like to start with some of the dialysis facilities, and you're welcome just to drop them in. And I'm sure Sarah Eve can take you off mute or elevate you for additional detail, but give me feedback on what is working with your transplant centers. And the reason I'm asking is because we want to take it back over to our work, right? We're all working, but we want to make sure we're working across. And I can provide examples. So we talked a little bit about the electronic health records or the EMRs. Referral processes. Again, if you work with multiple transplant centers, knowing that their criteria is different, knowing that their wait times are different, that it might take longer for some than others. We've heard great stories and recommendations and examples for what I call the one-day evaluation. The patients pull right up to the front, they park right at the front of the hospital. Then it's timed throughout so they can get their cardiac, their EKG, whatever, everything they need, their blood work, everything's done kind of in a cyclical way instead of going to one center to do this and making another appointment to do that and doing their PAP here and their mammo there, right? So what works in your referral process? What works for communication? Does your social worker, someone else in the organization, are they the point person at your dialysis facility, or does it go to multiple individuals? Do you have a representative for each transplant center, and that's where information comes in and goes? Do you have a protocol that says when a patient's hospitalized, we let the transplant center know right away, or do they not hear about it for a couple of weeks, right? Education, a lot of great education taking place in the dialysis facilities. We're hearing shifts from, one page, here's, your annual, let me know if you have questions, to sit down, chair side conversations, maybe with someone from the transplant centers, or having them come on site and meet with folks, to sending links where they can watch a education video on their phone while they're on dialysis and then verify or teach back. So this is what I learned, and here's what I'm taking away from it. And then that's documented as well. And then as far as your pre and post transplant work, and I'm seeing lots of notes in here. Thank you very much. That's what I'm looking for. And I want to give you time to type that in. And then Sarah Eve and Gayla, feel free to pull out one or two. But for your pre and post transplant, again, some of the organizations or transplant centers work very closely with the dialysis facility. That way, if there is delayed graft function, they do the transplant. It's very promising, but it hasn't woken up. It's not quite ready yet. So there's some delay. It's not a fail yet, but we want to give it time. We want to try to medicate or manage. So those patients might have to come back into dialysis for a few days, weeks, months. So that coordination around it is better at some centers than it is others. I love it. Thank you guys so much. I'm seeing the
yeah, and I'll save the chat and share it back out with both the participants and with the team here today. So, right, a lot of folks chiming in with good communication between the transplant coordinator, monthly follow-ups. Some folks are doing, quarterly check-ins or meetings.
Excellent.
We see one thing here from, Kaiser's piloting something with pulling out, although the person's in Northern California, they're listing them at Nebraska centers. It's only been a small number of patients, but again, neat to see something outside the box there.
Absolutely.
And maybe something too, Tina, I'm not gonna sugarcoat it. A few people feeling, maybe a little bit frustrated or, disappointed that perhaps, it's the transplant centers make it tough on the patients, or, that it just doesn't feel like it's helping. Any success stories or words of encouragement there from for the dialysis facilities as they continue to work with their transplant centers? Are the transplant centers receptive and open? Are they accepting this feedback?
I again, just as we talked about, there's 225 centers. There are 225 personalities in each of them, right? So I'm not going to say every transplant center is has the same level of support or communication or what have you. But I think as you're identifying those, something, just a strategy around might include things like, I work with 3 transplant centers, 2 of them are amazing. One of them, it's very difficult. So maybe it's pulling out some of those good stories in what works and then approaching those transplant centers to say, hey, this was working really well. Can we try it here? Instead of just getting the same feedback of we don't do that, or we're not going to respond again until whatever your negativity that's coming back. And maybe it's one person or 2 people or a group of folks, but I'm sure if that level of frustration is there, maybe approaching someone different in that organization, maybe going to your medical director and asking them to request a meeting with that team to say, hey, we want to get our patients listed, or I need to hear from you more frequently. Here's what works at other centers that we're working with. Can we try to do some of these here? Sometimes it's just getting that one-to-one, maybe having some leadership support in would be an initial recommendation.
Excellent. Thank you, Tina. Also, maybe perhaps maybe the dialysis facilities, y'all can call out something from education. If there's a resource you're loving or a mode, if it's one-on-one, Tina mentioned the videos, if there's a certain handout or a process, a timing issue, maybe some ideas from your part, dialysis facilities and networks on transplant education.
And I'm sorry, Sarah, was there, were they going ahead and typing in some things that works for their education?
We're finishing up some communication there. I do feel, right, we've seen a couple times here that the coordinators, are overworked. Meanwhile, the dialysis facilities are not sitting around eating bonbons either, as we all know.
And you're not there you're there to help educate, but you're not directly involved in their transplant process, right? So you want to encourage, but it has to be patient initiated. They have to be the ones doing and driving the work. They also, as far as the communication, sharing back with you, letting you know what's going on at the dialysis facility.
Sure. So as far as education, we're seeing, some transplanted former patients, and I know on past lands, there's been some talk about, some dialysis facilities not allowing former patients returning for a lobby day, but it does look like in some areas that's working. Peer-to-peer support, perhaps virtual events. One transplant center, UC San Francisco, is doing an online event next week for dialysis centers. And then also Laura saying again that lobby days have been effective in the clinic. And maybe just some clarity there from those of you who are mentioning lobby days. We're talking about former transplanted patients, or would you prefer to have the transplant center professionals come in? I know that might be a little bit more difficult with scheduling, but just maybe what might be in that lobby day. And then, too, what is missing? Are there gaps at the dialysis, both of them? Are there gaps at the dialysis facility level? Do you wish, I wish I had, if only the patients really need, I really need. Let us know there too if there's something that you think is missing at your level. So yes, transplant center professionals coming in, partner with local transplant centers for lobby days, both patients, simple one-page handouts. Some transplant centers providing lunch and learns with the staff. That's a nice wrinkle there too. We can't always be focused on the folks in the chairs, but also the folks providing care at the dialysis facility.
Absolutely.
Educating the staff. Lots of simple one-page handouts, peer-to-peer support. I will promote now just for a moment, shameless self-promotion there, that the ESRD NCC does have a peer mentoring program, as do some other organizations. This might be also very helpful for folks that are not English speaking. They can speak to a peer in their native language. Okay.
Excellent.
Tina, perhaps too, you want to ask the ESRD networks?
Absolutely, and thank you for noting what's missing. So if you had a wish list, or if a magic wand appeared and this problem was solved for you regarding transplants, drop that in too, so that we can take a closer look, see if there's some ways that we can connect to the work with ETCLC back to more of the dialysis facilities and ESRD networks too. And as we go into what's working at the ESRD networks, I'm typing in a quick note, but I want to let you know those resources that I showed earlier, in addition to a lot of other resources, including all the pacing events and case studies we've done, links, and the ability to rewatch them. They're in our ETCLC website. If you go to etclc.org, again, I'll drop it in here for you. There is a box on the top right that says ETCLC participants, and it says to click here to either proceed to what we call our ETCLC progress tracking system, or to register for it. I think this was offered over a year ago for networks to register for this particular site. At that time, we were still using a separate site, so it was limited, but now we've since merged or migrated everything over to this location with a simple email and password. So if you haven't, please go there, register. Mark from our team is already ready to get you into the site, so it'll go pretty quickly. But again, a lot of great resources there. All right, so for our ESRD networks, would you do me a favor and maybe even raise your hand if you want to come off mute? But I want to hear more about some of the work that's taking place in your coalitions. Are you finding out similar themes or challenges in those coalitions that I talked about today? Are there new ideas that I didn't even touch that we should be looking at or bringing forward to our groups? And then I think you're meeting quarterly. Sorry, Sarah.
No, that's fine. I'll just mention that these calls, actually, folks cannot unmute themselves. So if you would like to share, we shut it down. Sometimes we get rather large. So if you would like to come off mute, I can promote an ESRD network professional to panelists if you'd like to share live.
Okay. Thank you. And I want to keep you on schedule. I like that you guys end your calls a little faster, or it's a nice surprise to get a few minutes back. But would love to see just a couple of comments from our networks, because I know you're working hard in the space as well. And then same question, what's missing? What have you identified in working your coalitions the last, I think you're at least 2 years, if not 18 months into your work as well. What keeps coming up as a stumbling block, a challenge, a barrier that you haven't necessarily found a solution for yet?
And while folks type that in, I will say we did get a few things in the wish list category. California talking about moving to living donation conversations, given the long wait time out there. You know, some more referral requirements, resources, perhaps a list of testing so patients can begin earlier. And here we are weighing in now with the networks. Communication with transplant facilities, turnover in the transplant coordinators is an identified issue. From Brianna, talking about her coalition continues to break down barriers. We recently developed a transplant roadmap in partnership with 2 other networks. It outlines the whole process. And she identified the gap is asking transplant centers to have a pool of transplant support partners that can help people who live alone. We need a better way for rural patients to complete the evaluation criteria without requiring expensive travel.
Great points. Great points.
Sorry,
do you have any closing? Do you have any closing slides, or are we doing okay on time? I just don't want to.
No, we're doing okay on time.
Okay, great.
We just like to remind everybody. I'll pause here and say that as long as we get the okay from Tina and her contracts core, we will share these slides out following this presentation. The NCC shares them with the ESRD networks, who can then distribute them within their network service area. We don't individually blast them out to dialysis facilities, but you will have access to the slides for the network, and then also we will post this video in about a week to our YouTube site.
Great, thank you.
Okay, so another comment then about the, post-transplant support people. One center is now requiring 2 folks. From one of the networks, we have a coalition in New Mexico that includes 2 transplant centers that address living donation, and also partnering with NKF for an in-person event with concurrent presentations, given both Spanish and English.
Fantastic.
Yeah, Maheen, I will drop in the NCC YouTube link in there. You can see this and all of our past recordings of our lands in there.
Excellent. Well, Sarah, it is an absolute pleasure to be here with you all. I felt right at home coming back into the networks and the dialysis facilities. Appreciate everyone's time today. Great questions, great comments. As Sarah said, she's going to be sharing that back out, including with us. If there's anything that I see in there that we can answer and get back to you on, I'll be sure to send that over to Sarah Eve too, so that when you receive the materials and the notice about the YouTube posting, then you'll get an answer to the question as well. The next slide will show a general email that you can send to us, as well as our, I'm sorry, the email isn't on there. but you can find us at that etclc.org site. Again, for the networks on the top right, it says ETCLC participants. Just click on register, quick way to do it, and then you can go in and take a look at some of the other resources. To meet with us or to follow us on social media, obviously we want you to do that. We're just building that in this contract year. So new to X or Twitter at ETCLC1, and then on LinkedIn right now has been our primary for the professionals in transplant and how to best connect with them. But just type in ETCLC in the contacts. And for my email, for folks that would like to follow up, it's tdinkel@hsag.com. I'm going to just drop it in here if anybody has other questions, wants more information, or anything we can do to help continue to partner with you. Sarah, it's just nice to be a part of the conversation with the incredibly talented and amazing dialysis facilities, again, that work with these folks, try to encourage transplant or identify patients that may not be a good candidate, but encourage them to consider other modalities maybe, or give them the right resources so that they can have a great quality of life as well. And of course, our ESRD networks that just do the brunt of the work, and a lot of changes over the last decade since I was here, but wonderful to see some familiar names. And thank you so much for your feedback in this work, as well as your partnership in a lot of the things that we're doing. So thanks, Sarah.
Excellent. Thank you so much, Tina. And as Diane said, it is great sometimes to review some of the other work that's being done at the macro level. So you know that, right, this is the whole zeitgeist right now is working on transplant and optimizing donations. So I'll pause here one more time to plug the ESRD NCC change packages. We do have one for transplant. We update it every year. We just finished our interviews, and so we'll be updating that along with 2 new resources for transplant, and actually for each of these OKR topics per change package. So stay tuned to the NCC. We have some good stuff coming out later this contract year. And to, find and follow us on social media. We're on Instagram. I put the YouTube link in the comments. If you need that, past lands are in there too. And again, we will share the deck and the chat with the ESRD networks to distribute in their service areas. Thanks so much. Excellent call today. Thank you for all that you do. And until the next ESRD NCC land, take care.